Thank you very much. Delight to be with you, or not to be with you. I apologise for not being with you in real time, but happy to record this. So I've been asked to talk about neuropsychiatric symptoms in dementia and treatment. And the phrase that I'm going to take here is the phrase that the drugs don't work. And we're going to use that to illustrate some of the issues in the management of neuropsychiatric symptoms of dementia, and some of the emerging research that has been carried out in this area. So where does the drugs don't work come from? Well, there we go. So it comes, of course, from the 1997 Britpop album Urban Hymns by The Verve. And Richard Ashcroft, with his very long shoes there, you can see those there, he basically sang in the song that the drugs don't work, they just make you worse. And I'm going to suggest to you that that's exactly what happens with the use of most medications for the treatment of agitation in dementia, that the drugs don't work, but they do have substantial negative effects, and those substantial negative effects cause problems for those people who are prescribed those medications. So neuropsychiatric symptoms of dementia are common. About 90% of people with dementia will have them at some stage in their illness. And they are a kind of less spoken about part of dementia than the cognitive impairment or the functional limitation that people talk about all the time. But neuropsychiatric symptoms are what drives poor life quality, and I'm going to come back to that with some data in a little while. And also the social impairments of dementia are very strong determinants of breakdown in carer relationships, and cause problems for both people with dementia and their carers. And again, they're much less spoken about than cognitive impairment and functional limitation. And the very phrase neuropsychiatric symptoms is a portmanteau term. It's a portmanteau term for a set of different conditions. So agitation, aggression, depression, sleep disturbance, psychosis, apathy, these all fall under the terms neuropsychiatric symptoms, but right from the beginning, and I think this is an important point to make, you see there is considerable heterogeneity in this group. You're including both apathy and agitation, for example. There's depression and psychosis. Some of these things look like other mental disorders that we are used to treating, but the question has to be, though it looks like it, is it really that? So is what we use to treat depression likely to work for depression and dementia? And without giving anything away, the answer is no to that. And is what we use to treat, agitation in schizophrenia, is that likely to work for agitation and dementia? And we'll take a look at some of the medications later in this talk. But let's focus down on agitation, which is where I'd like to focus just at the moment. Agitation, it's common and it's persistent. So if you have agitation, about 50% of people with dementia become agitated at some time in their illness, then it can persist, and that causes major problems for the person with dementia, and also major problems for those people caring for them, be they family carers or paid carers in care homes or within their own homes. And there are different sorts of agitation: verbal agitation, non-aggressive agitation, aggressive agitation, and again, they may be mixed up, and they may be mixed up with other neuropsychiatric symptoms as well. So again, what neuropsychiatric symptoms don't have is that they don't have the characteristics of a specific illness or disease. It's much more indistinct than that. So let's think about what are the causes of agitation. And the thing that I'd like you to take home from this slide is that dementia is right at the bottom. I think that many of the issues and problems that we have are caused by an assumption that dementia is the cause of the agitation, that actually it's not caused by anything else, that actually the fact that an individual has Alzheimer's disease or a vascular dementia or or a frontotemporal dementia or whatever, the fact that they have that dementia is excuse enough for an individual to have agitation, and excuse enough for that agitation to be treated with a particular medication. And it is, of course, the case, as you will know well, that agitation may be caused by unmet needs, and you only have to carry out the thought experiment of placing yourself in the situation of not being able to communicate, of not being able to understand what's going on, of not knowing what your needs are, of and then to have people doing things to you, or attempting to wash you if you don't feel that you are dirty, or attempt to and get you up out of bed if you feel that you don't need those those helps. But unmet need, pain, hunger, thirst, constipation, delirium, none of those are treated by an antipsychotic medication or an antidepressant medication. Response to stimulus and environment, the under and overstimulation of care homes or of acute wards, for example, overcrowding, inconsistencies in routine, provocation by others who may be shouting themselves, noise, light, activity, all of those things can make an individual agitated. And again, if you imagine yourself as having the impairments of dementia, of course you would become agitated in those circumstances, as you would if you were unable to express your psychosocial needs of stress, of loneliness, of depression, of lack of purposeness. And then you add into that the responses and the approaches of carers who you may not perceive to need, but who appear to be, laying hands on you and trying to, they obviously are trying to help, but you are not perceiving that help as help because of your cognitive impairment. And I think that what I'm rehearsing here is there's just so many different reasons for an individual to become agitated, and so few of them are likely in any way to respond to medication. But all of those situations can respond to a careful approach of imaginative care planning, of assessment, of support, of things that are not drug-based. And in terms of the evolution of language, I think it's interesting to see where language comes from. I've used the term neuropsychiatric symptoms because that for me feels a kind of neutral term, and it makes the points that I want to make about the breadth and the heterogeneity of experiences within that. But it is interesting to note that behavioural and psychological symptoms of dementia, which was very commonly used before and is still very commonly used as a portmanteau term for these conditions, was actually a term coined by a drug company sponsored group in order to create a target for psychotherapy. Not psychotherapy, sorry, pharmacotherapy. Challenging behaviour. The question then is, challenging who? Is it challenging the person with dementia for them to be walking around at night, or is it more challenging for the ward staff or for the care home staff for that to happen? And we have terms that have evolved like responsive behaviour, which bears some sort of witness to the idea that some agitated behaviours may well be meaningful responses to the environment, and that they might reveal underlying concerns like pain, like loneliness, like not wanting personal care, all of those sorts of things. Again, not necessarily things that you would, on reflection, imagine would be usefully medicated. But what is absolutely true, and this is why people want to help and treat people with agitation, we know that it is not a good thing. I mean, the prognosis may depend on cause, but we know that agitation, when it exists in dementia, causes deterioration in the relationships between the person with dementia and their family carers, and also with professional paid carers as well. We know that it can increase admissions to care homes, as the care arrangements break down within people's homes. We know it can increase hospital emergency admissions, increase the costs of care, increase carer burnout and carer burden, and profoundly decreases the quality of life, not only of the person with dementia, but also of the carer of that person with dementia. And here I present some data from a study when we were developing measures of quality of life for people with dementia, which is essentially the overall well-being of individuals. What you'll see is these are correlation coefficients, and the bigger the red line, the more the correlation. And you'll see the things that drive poor life quality are the things that are in the NPI there. That's the neuropsychiatric inventory. Those are neuropsychiatric symptoms, and they are the main drivers of quality of life. If you look at the top and you look at those, those more popularly understood bits of dementia, ADL, activities of daily living, functional limitation measured by the Bartel index, there is no association cross-sectionally with functional limitation or with mini-mental state, and therefore cognitive function. Those have no relationship, those bear no relationship to life quality, and that's because they happen gradually, people adapt to them, whereas agitation happens in the moment and causes major difficulties. So it is entirely reasonable that people ask for help with agitation. It is entirely reasonable that we should seek to help those individuals, because it is a major determinant of poor quality of life for people with dementia and their carers. So let's ask the question, do the drugs work or do they make it worse? So a quick romp through pharmacotherapy for agitation and dementia. Start off with anti-dementia drugs. Donepezil doesn't work, and the other drugs, the other cholinesterase inhibitors also appear not to work. Memantine, when it first came out, it was sold as helping agitation, but there's no real evidence to suggest that it does work. It's given to people with severe and moderately severe dementia, but it's a treatment for that dementia and cognitive function, not a treatment for agitation. Anticonvulsants have been used, valproate, carbamazepine, gabapentin. There is no evidence that any of those medications are better than placebo at work for that. There may have been the odd trial a long time ago, but really take a look dispassionately at the data. No evidence that they work. Benzodiazepine, there are actually no trials of benzodiazepines, and that's because they cause so many problems in terms of falls that it would be very difficult to carry out such a trial. Now, citalopram, which is an SSRI, in the CIT-AD trial, did show that it worked a bit. Not very much, but it worked a bit, particularly in those who you would be least likely to wish to treat, those with least agitation. It also worked best in those with least cognitive impairment, but it was noted to cause adverse cardiac events and also to impair cognition, both of which limit its use otherwise. Antidepressants, very widely used as substitutes for antipsychotics, particularly mirtazapine. Mirtazapine, the most commonly used substitute for antipsychotics in people with dementia, but no data on whether they work. And again, I'll come back to some new data on that we collected. Antipsychotics, well, they do work a bit. There is efficacy in terms of causing sedation through the side effect of antipsychotics, not through not through decreasing agitation, through decreasing psychosis, as they do in schizophrenia. They do work a bit, but they have major adverse events, and we've known this for 20 years. Ever since data started coming through with aggregate data on risperidone of a higher rate of serious cerebrovascular side effects in those people receiving risperidone compared to placebo. And what's become clear over the last 20 years is that all antipsychotic drugs share these severe cerebrovascular side effects and also an increased mortality. And that mortality is specific to people with dementia. So this is an increased mortality and increased side effects that happen more in people with dementia than people without dementia, even if they have other physical illnesses. And I was asked to carry out a review of this back in 2009, and we found that there was a very high use of these medications in people with dementia, with up to a quarter of people receiving an antipsychotic in a year, and that equated to 180,000 people with dementia receiving an antipsychotic, and that meant that antipsychotics were causing 1,800 deaths per year that would not have happened had those people with dementia not been on antipsychotics, and about the same number of severe cerebrovascular adverse events. And there's been fantastic work throughout the UK in making this clinical governance priorities, and we've driven down the rate of prescription of antipsychotics in dementia by a half in the UK, and that's a real positive step. Just recently, with the pandemic, there has been an uptick in their use, a simple answer to a complex problem that is wrong, the prescription of antipsychotics for dementia, but one can understand how in the pandemic presented with very few other options, the willingness to prescribe these medications reasserted itself in our systems. So we carried out a randomized controlled trial, the Sinbad trial, to see if mirtazapine worked for agitated behaviours in dementia. So we took 26 UK centres, we recruited 250 odd individuals, and we randomised them either to receive placebo or to receive mirtazapine in order to see if mirtazapine works for agitation in dementia, and it doesn't. These are the blue line is placebo, the red line is mirtazapine, and essentially there is exactly the same response in the placebo group as there is in the mirtazapine group. The drug does nothing more in any group or subgroup compared to placebo. So the most widely used medication for agitation in dementia does not work for agitation in dementia. What it does, however, do is increase the number of adverse events and severe adverse events compared to placebo, severe adverse events. And there was also an excess of deaths in the mirtazapine group compared with the placebo group as well, though that did even out at 1 year. So drugs do not appear to work and do appear to cause side effects. So, why? What is it that's happening here? Why are we here? And as I alluded to, I think that the issue that we have here is that we're looking for a simple problem a simple answer rather to a complex problem. Agitation in dementia is a complex problem. Prescribing a drug of any sort is a simple answer to that complex problem, and it just doesn't work. But there are things that do appear to work. And if we look back at those, if you remember back to those slides, there was improvement. It's just, it wasn't a function of the antidepressants. So what does work for agitation in dementia? Well, almost anything that you do that is a systematic non-drug treatment appears to work. The 33 trials in this systematic review from 2014, all of which show positive improvements, decreasing agitation by providing person-centered care, communication skill training, activities, music therapy. It almost doesn't matter what you do, but if you're careful and you engage individuals, you can start to decrease the amount of agitation that they have, which then makes us think back to those other reasons for agitation other than dementia, which are likely to be generating much of the agitation. But the question is, where do you get non-drug treatment? GPs, physicians, care homes, carers, they feel they have no access. Community mental health teams do not provide that service to the whole of the population of people with dementia. They're not prioritised to provide it. They're not commissioned to do that. They're not commissioned to do that. My apologies. They are not commissioned to provide it in the volume that it would need to be provided in order to do that, and they are in effect rationed by referrers and providers. So that's why one ends up prescribing, or that's why some end up prescribing, because there's a feeling that these things are not available. However, if you look at what's in the box in terms of these things, you'll see that they are, you'll see that careful care planning, an imaginative approach to supporting individuals, the sorts of things that often happen in good care homes, and that sometimes families find ways of doing. Those are all the sorts of things that may prevent and treat agitation in these groups. So this is coming back to the Sinbad trial. You can see that there is improvement, and I think that that improvement is due to the treatment as usual that individuals get rather than the drugs. The treatment as usual, of course, is that problem solving, is that support, is that care planning, given by the nurses and the multidisciplinary staff in community mental health teams, but also provided by other teams engaged with dementia. And this is data from another study that we carried out on depression in dementia, and we see exactly the same pattern, that people get better, but it's not to do with drugs. So I think that a broader approach to neuropsychiatric symptoms would inform a broader approach, looking at both depression as well as agitation. So I suppose the take home is that the drugs may not work, but we do. We being people engaged in helping and supporting people with dementia, no matter where we're doing it, no matter how we're doing it. Non-drug treatment works for individuals with agitation. So just in summary, the effects that we're observing, I believe, are due to treatment as usual, but of course treatment as usual by community mental health teams is actually very rare. Outside trials are those lucky enough to be referred in and taken on by those teams, which are generally those with the most severe forms of anxiety, agitation or depression. The effects aren't due to placebo effects, so it's not the magic sugar pill, it's not the it's not a Hawthorne effect whereby individual recruitment to the study does it, and it's not regression to the mean. I think it shows that mental health services and services that focus on improving mental health can and do work. So agitation and dementia, they're complex phenomenon. They demand and respond to a complex approach to management as well. And that's what is needed. It's the rationale for secondary mental health services. It's the rationale for good quality personalised care, person-centred care in care homes. It's the rationale for listening and working with the families that we work in, both the people with dementia and their carers, and that we should assume that neuropsychiatric symptoms are caused by something other than dementia. It should be a last assumption that they're caused by dementia and not a first one. And pharmacotherapy, for me, is not a first-line treatment, except in the most extreme circumstances. I do use antipsychotic medications, and they are necessary at times, but they shouldn't be the default setting for individuals. And there's no sign that antidepressants help, other than citalopram, which has its own problems. Antidepressants like mirtazapine have value in the treatment of agitation and dementia. We need to face up to the fact that if we're giving those sorts of medications for agitation, the person we're treating is ourselves and not the patient that is in front of us. And I believe that people affected with these really difficult problems like agitation and dementia should have a right to safe, effective and treatments, and which is essentially having a right to good quality community care. So thank you for that. I'm sorry I'm not with you to answer questions. I hope that was of interest, and I'd be delighted if you wish to correspond with me by email at shivi.banerjee@plymouth.ac.uk. You can find me easily. Then I'd be delighted to answer any questions you might have. Thank you.
Thank you so much, Dr. Banerjee. That was a great presentation. Thank you so much for that. And I'm sure people will be sending some questions through, so thank you.